put it in perspective, let us understand that if it was a country, if this all the children with disability or children with development disability was one country, it would have been the third most populous country in the world, and which includes it is larger than United States, Indonesia, Pakistan, and every other country other than India and China. So that's the scale of the issue. And when you consider the overall disability, 1.3 billion people, that is 16% of the global population, live in significant disabilities. When we say about millions and billions, there is an inherent problem in that. Like I have said in the last discussion also, that we don't actually, we cannot actually understand what exactly is 1 billion and trillion, or maybe a million and billion, without understanding the scale of that. So let me put it into something which we can which is palatable. So 1 million seconds, 1 million seconds is 12.5 days. 1 million seconds is 12.5 days. And can anyone guess what is 1 billion seconds? It is 32.7 years. So that's the difference. 12.5 days versus 32.7 years. And 1 trillion is 32,700 years. So that's the difference between million, billion, and trillion. So 1.3 billion is a huge number. That is 16% of the global population. And as we said, it is around the population of India. Our is 1.46 billion. So children with, why this the problem is that the children with disabilities, there are multiple studies which WHO has come out with, and overall disability, the people with disability, overall disability, not just children, disability in children, people with disability die around 20 years earlier than people without disabilities. And you may be thinking that that's due to the disability or the health condition. No, that is due to inability to access to services, primary reason for that. So 20 years of life is taken away just because of the system failure. And now we see children also have higher mortality rates from preventable causes like epilepsy, choking. Even choking is more in children with disabilities. Lower school enrollment, poorer health outcomes, and systemic exclusion, among many other conditions, are a major reason why disability among children is an important issue. And there are enough studies to show that the non-communicable diseases like diabetes, heart disease, obesity are more in people with disability than without disability. That, as I said, that is not because of their disability per se, it is because of the conditions, the inability to access the services. For example, if you have a program, for example, let me say reproductive health program. You have many programs for people who are otherwise without disabilities. So, but when it comes to people with disabilities, there is no public health program. When you design a public health program, maybe it is a TB program, non-communicable disease program, diabetes program, hypertension program, any program, you don't take person with disability into consideration per se. That's why WHO is currently advocating for inclusion of disability as a sector in all the national programs, not as a standalone program. We want disability to be incorporated into every national program and not just a standalone program. So, early intervention, as Dr. Idris was mentioning here, on the first 1,000 days. So if you see, the 80% of the brain development occurs in the age of 2, and up to around 1,000 new neural connections formed every second during this period, every second. And neuroplasticity is maximum, as you know, and the brain is most receptive to the intervention. And there are interesting studies on that. There is a study in which primates, especially monkeys, were blinded for initial 3 years. The sighted monkeys were blinded for initial 3 years, but after that they can't really see, because the seeing as a ability actually comes through a lot of neural connections. Every of our actions, every of our abilities are based on many neural connections, which really don't happen without simulation. So by adolescence, the brain prunes away unused connections by 50% and making early intervention very critical. So, WHO has developed many framework and including the WHO UNICEF Nurturing Care Framework, which just came in 2018. That's something everyone has to go through because that's a huge resource in that. WHO guidelines for improving early childhood development, which came in 2020. Then a global report on child development disabilities, which came in 2023, and Rehabilitation 2030 initiative. This is a major global initiative which has come up in 2023. And there is a World Health Assembly resolution. If you know, recently I was having I'm actually coming from a conference of the regional conference where we had governments participating from 11 countries in the 10 countries in the Southeast Asia region of WHO. We were discussing on how to improve the eye care. So I said to the government delegations who came over there that it is not like WHO has an agenda. WHO per se is nobody to have an agenda, because WHO is led by something called World Health Assembly. And who is World Health Assembly? Just to put in a context how the things work. Since 1948, you know what was the life expectancy during 1948? Any guess? Below 50. Below 50, and there were places in the world where the life expectancy were around 27 to 30. In that case, if you were born at that time, most of us would have not be here, so because we are already over the life expectancy. So, but when there was a lot of issues, one thing which the world came together is that health need to be above all borders, above all consideration. Health need to be the primary consideration. So the world countries came together in 1948 and sat together and decided to prioritize health, and that is the formation of the World Health Assembly. And WHO is thus the operational secretariat of World Health Assembly. And when you say the World Health Assembly constituted at that time, and the world prioritized health, if you go through the World Health resolutions of last 80 years, I was going through an analysis of that. It is interesting to note that it's the evolution of human health. At that time, initially we had the problems like smallpox and many other conditions, plague and some cholera. This was a major consideration during 1948 to early 70s. So that was our primary considerations at that time. When we eradicated more smallpox, many other things happened. Then in late 80s, we started talking on disability. And by only 1990s, we started talking on early interventions, what we need to do, assistive technology, rehabilitation. And you know, the history goes like this. By 2023, only by 2023, the human of this world decided that rehabilitation need to be a mainstream in the public health delivery system in India. So the first resolution in the world on rehabilitation being the mainstreaming or mainstreaming rehabilitation in the health system was in 2023. That shows that we are late in acting, but still it shows the evolution of the history, evolution of how the medical science progressed. So we are in the cutting edge of the human evolution, to be real, if I put it in that way. So, and I must also acknowledge that when the world started thinking that we started the rehabilitation, mainstream rehabilitation much more earlier than that. I must acknowledge that when Ashraf sir was the Social Security Mission director, he actually started many activities on mainstreaming rehabilitation into many other. Even the health department was standing when the concept of this early intervention system came. It was the first time where the social justice and health has to come together, and Social Security Mission decided to invest in setting up of district early intervention centers. Many other things actually came together. So the mainstream of rehabilitation, the link of health and social justice in rehabilitation, I must say that initiative came from Dr. Ashraf sir when he was a Social Security Mission executive director, and that was first of the unique thing in India to happen at that time. Now we are talking a lot on that, but this when it came, it was, and much more before the evolution of when WHO thought of that. So that's a reality which we have. So when we talk of levels of prevention, as you all know, and I don't want to this priest to the converted. So this is comprehensive approach. You already know about the comprehensive approach of prevention of. We don't call it prevention of disability. Let us be very clear on that. In WHO, we can't use the word prevention of disability because there is a huge thought that disability is not something not to be prevented. There is a lot of conflict of discussions on that. Disability is something we ignore, but disability is a creation of the social construct. Someone can born with a health condition. Someone is born with a health condition that may cause a physical impairment for them, but disability is the inability to participate. So we really when we say prevention of disability, we are not saying that we are eliminating. We don't want eliminate. For example, eliminating deaf people is not our consideration. Eliminating people with blindness is not our agenda. We want to create an atmosphere wherein which a person with disability can also be part of that system. But obviously, we would still prevent the health condition which can link to them to that social isolation. That's another whole system. So that's a interesting thought which is coming up. So this is primary prevention. As you know, the immunization programs, the congenital, and just to mention on that. In fact, when I was I came to Social Security Mission, one thing which was, why is Social Security Mission investing in MMR vaccination? So that was a question every time. The planning board also asked that, why MMR vaccination? That is what your consideration in that. What is your importance in that? Why are you doing that? So in fact, then I had to answer just to share an experience on that, which I think is a relevant thing, and because when in government, every decisions you make is actually affecting the population. So there was a situation where in 6 months our MMR vaccination was got hold because the finance department thought that it is not to be done by the Social Security Mission, and health was not doing that at that time. So I had to mobilize some other funds which was not in that head, and I actually channelized it and restarted the program which was happening during Ashraf sir's time, and we restarted the program. So the finance there was an audit on that, and I was sitting in the AG, PAG, that is Principal AG, asked me that without an allocated fund, why did you restart the program without a government order? And then I said there is a lot of confusion. Now that confusion is there, but you can't start a program by yourself. You can't restart a program. There is a government order in that. So what I said, sir, this is about MMR vaccination. Now, you are saying that the MMR vaccination for a cohort of who is born during these 6 months is not done just because there is a problem with the government orders. There is some assistant in the secretariat doesn't seem to be important. So what happens is that this cohort becomes age to this cohort of this cohort of children born at that time. After 16 years, they became young adults, or maybe after 18 years, this cohort actually moves together, right? And they get married, and someone is having a congenital and their babies are having congenital rubella syndrome. So the question would come is, why were they not immunized? Because 16 years back, some person in secretariat thought that this is not important, and 16 years back we did not recognize the importance of that. That's why the children, after a child is born with the congenital rubella syndrome. So that's the relevance of each decision. And when I said this to the principal AG, in fact, they actually gave an appreciation on that, saying that that was a decision to be taken on a bona fide intention. So many times each of the interventions, each of the actions we take now, and that exactly is relevant to this all the context. We really doesn't know what we prevent. All the action with Tunnel took, all the action Dr. Idris took in the last maybe more than 15 years, if you actually extrapolate on the life saved, on the quality of life, the difference in the quality of life, the disability averted, the DALYs and QALYs, if you calculate, it should be huge, and maybe that's something which we need to do to quantify what the job we have done. So just coming back to this. So primary prevention. Yeah, I have 15 more minutes. Yeah. So immunization programs, genetic counseling, we have the expert in that. I'm actually looking forward for Vinod Skaria's presentation. In fact, he threw me many interesting hooks on that. On we will be getting something, and he was very much vocal on the genetic newborn screening here. So I'm looking forward to hear more about that. So folic acid supplementation, and in fact, road safety measures are also a disability prevention, or maybe preventing a health condition causing disability. Because road crashes, I look after road crashes also, so that's my favorite topic. And road crashes is the number one killer in children and adolescents. Number one killer. Everything comes after that actually. Children means above 5 years, not that's children by version of that, 5 to 19 years. So 5 to 19 years number one killer is at the global level, and in most of the developed nations is the number one killer even in the less than 5 years. We are not the road crashes are not number one killer in less than 5 years in low and middle income countries is not to be credited because of the road safety measures there. It is just because diarrhea and URI and respiratory infections continues to be the number one killer, not because they have a better road safety measures. So then prevention of infectious diseases, improved maternal nutrition and antenatal care all contribute to the primary prevention of disabilities. This is based on the global evidence. I just re-emphasizing that. Then obviously the early detection and interventions, which is the primary topic here. I really don't want to describe more on this. Then the levels of preventions includes tertiary prevention, which is rehabilitation services, as I told you, on physical, occupational, speech therapy, all the possible rehabilitation services. Then assistive technology provisions. In the last presentation also, recently I had an experience. We were having a kind of meeting of CG, the cochlear implantist group. So cochlear implantist group, then I was actually giving a speech over there. So I remember about a incident which I had recently. So one of the child, I may not call child, when they got implanted, they were a child. So a girl who got implanted in her early ages matured to become a doctor later. So she after passing the examination, she joined in one of the private hospitals. I went for her marriage. So the groom's relative, in fact groom's father, called me and said that whether she will be continued here because she is having an implant, how well it will work. Then I told him that when the first implantation was done, what she was using was print model, which is a very old model of you have to carry the processor with you. Then it was upgraded to what we call as BT, behind the ear processor. Then it got across a console model where you don't see the processor outside, that is hidden in the hair, hidden between ears. So now every passing year, her hearing gets better. Why? Because the technology gets better. And I told him that by every passing year, your daughter-in-law's hearing get better, but your son is having natural hearing. That will deteriorate by every year, and by the end, there is a possibility that your son may become deaf, but your daughter-in-law will not become deaf. So that's the power of technology. So assistive technology has that level of, and it's not. Mark my word, by next 10 to 15 years, we will have a situation in which people will go for cochlear implantation even though they are having normal hearing. So that's actually make them superhumans. In fact, we had to, one of the model which AB, one of the company came out with a model in which now all the models have Bluetooth facility. So we had to reject that model during the tender pre-bid. Why? Because one of the educational expert pointed out an important thing. What if that student decide to do a malpractice during an examination? Cochlear implant is having the Bluetooth. So someone can actually dictate from outside, and they can do that. And it's a perfect crime. Why? Because even if the invigilator know that, if he takes out the BTE and put on his ear, he can't hear because he don't have the implant. So it's a perfect crime. Nobody can actually prove anything. So we had to reject that model. So that's a facility. Now even there are new models coming with zooming and all. That's another thing. So this was a program which Ashraf doctors are actually during the initial the Srudidarangam program. There was a kind of a backward and forward lineage of the linkages of the Srudidarangam program. So this is a classical example of where an intervention can happen systematically to prevent a condition, health condition causing disability. So this is you start a universal hearing screening. All the babies born are screened for first month of life, 1, 3, 6, 18, 42. By third month you go for a BERA confirmation, brainstem evoked response audiometric confirmation. Then by 6 months you go for a hearing aid, and by 18 months we go for a cochlear implantation, and by that 42 months the baby born with a hearing disability is actually convocated, literally convocated at niche to with a speech and song to a child with speech and hearing. So that's the power of early intervention, and which we can do. And I don't want to say to this August crowd because everyone knows that the power of early intervention. So this was something. This is the Bretley. We actually went to many of the states for Bretley. Bretley, right? There are people who don't know Bretley. So let me tell you. So in fact, I was having I called Bretley. I took Bretley for a program in Alappuzha Medical College for Onam. So it was called as Lee Onam. So the principal of the Alappuzha Medical College at that time, she was giving this welcome address, and he said, what he does in cricket? Then in bowling. I have seen. He bowls okay. World's fastest bowler. He bowls okay. so anyways, what happened is that with Bretley we went to many places, many states where they start the for the newborn hearing screening, and the impact of that when I am in WHO now, I was able to follow up with all the states to take it forward, and we are actually restarting the program in many other places, including Karnataka is having a. Now, if you ask me, the best cochlear implantation program is currently with Karnataka. So second comes Tamil Nadu, and maybe we are in the third position, and many other Haryana, Rajasthan, we are working with few other states to make a program better. So having said that, what would constitute a components of the ideal system? So it should have an acute with a clear or a perfect antenatal care and immunization program. It should have a newborn screening. I am happy that I don't think sir also will be joining. He actually devised the RBSK program. So many of these are already addressed in that. Newborn screening, a perfect newborn screening, a developmental surveillance. You need to have a developmental surveillance. Of course, early diagnosis of the conditions and a comprehensive early intervention, and the rehabilitation and access to assistive technology as I detailed. So this would be looking as an ideal system. And most of this, or if not all of this, are currently being addressed by institutions like Dhanal, and we have to scale it up at the national and state level, because when we sit in Kerala, we may not realize the acute need for that. We know that there is a huge need, but the unmet need, the extent of unmet need, if you go to many other states, it will be quite obvious to the people. So there are many success stories, obviously from India, the District Early Intervention Center. That's the child of Dr. Arun Singh. So this program, this District Early Intervention Centers, along with the RBSK program, was a revolutionary program in this. Bangladesh has a huge and very nice program on community-based early intervention. I must say that Bangladesh may be having one of the best community-based early intervention program. Kenya is having a group-based parenting intervention. They're focusing on the parents. It's primarily, it was a US-aided program, but currently also they are running it well. Jamaica, they were doing a simulation program, like actually stimulation program for psychosocial stimulation program for children who are young. Then they found that there is a 25% increase in the overall economic productivity of the country. So that's and primarily this was attributed to the psychosocial simulation program in happening in children. And Vietnam, there is another important program. In Vietnam, there are many interventions happening in health. That's a huge. I was in Vietnam for last 2 weeks actually, in the early of this month, starting from second. So we came through many of the health system development over there. It's really amazing. So now, to conclude, let's hope and let's imagine a world where every child is screened for developmental delays, where every child is child identified with disabilities receives timely, appropriate, family-centered intervention. Every family is empowered with knowledge and skills to support their child's development. Every community has accessible early intervention services. Every health worker is trained to promote early childhood development. Every nation has sustainable financing for early intervention within their universal healthcare delivery. And disability is understood as a diversity and as not a deficit. And inclusion is the norm in schools, workplaces, and society. This is how we envisage. When we say that, at least some of you would have thought in that എത്ര സുന്ദരമായി നടക്കാത്ത സ്വപ്നം അല്ലേ. So, but as I say, we have to dream first. And there are Paulo Coelho. In which book? Alchemist. He said that when you want to something, all the universe conspires to helping you in achieving it. So, when I say this to many of the people, people doesn't really appreciate what he said. So what I do is same dialogue was said by this person, Shah Rukh Khan. So in the movie Om Shanti Om, how many of you know Hindi here? Okay, so pretty good crowd. So I can say it Hindi itself. इतनी शिद्दत से हमने तुम्हें पाने की कोशिश की है कि हर जर्रे ने हमें तुमसे मिलाने की साजिश की है. कहता है अगर जिंदगी में हम किसी भी चीज़ को सच्ची दिल से चाहे तो पूरी कायनात हमें उसे मिलाने में जुड़े रहते हैं. फिल्मों की तरह हमारी ज़िंदगी में भी अंत में सब कुछ ठीक हो जाता है. अगर ठीक नहीं हुआ तो वह दी एंड नहीं है. पिक्चर अभी बाकी है मेरे दोस्त. थैंक यू वेरी मच.
Thank you, sir, for providing such a powerful